My name is Daisuke Matsuoka, and I'm a pediatrician specializing in pediatric nephrology in Japan. So today I'd like to introduce pediatric nephrology. First of all, let me introduce a phrase commonly used in the field of pediatrics. This one. Children are not little adults. While this concept originates from theory in the field of education, it is highly applicable to the medical field as well. It means that children are not just smaller versions of adults. They are fundamentally different. Therefore, today I'd like to focus on the differences between adults and the children in these areas: physiology and kidney disease and kidney failure and dialysis. So let's start with pediatric physiology. Of course, adults and the children differ in size, but their vital signs are also different. These differences vary not only between children and adults, and also across different age groups of children. You can see in adult, adolescence is same as adult. The normal pulse rate is about 60 to 100. The respiratory rate is around 10 left per minute, and the blood pressure of about around this level are normal. However, in neonate, for example, the pulse rate and the respiratory rate are almost twice those of an adult, and their blood pressure is much lower than adults, 760 or 70 or something. Now, let's hear what it actually sounds like. First, it's the sound of an adult heart. Here. Like that. This may be a familiar sound, right? Now let's hear the sound of a baby's heart. What sound? Oh, like this. Pretty first, right? And the bar sound is so. Let's take a look at the baby's breathing. Like that. So breathing is also first. It's a normal in adult, it's an abnormal adult, but that's normal in a baby. Now, how about the kidneys? Let's look at the kidney size first. The size of the kidneys at birth is about 5 centimeters, and they gradually grow to adult size by around 15 years of age. In terms of kidney function, newborns' kidney operate at about 20% of adult level, reaching nearly adult level by around 3 years old. The ability to concentrate urine is immature, and sodium deabsorption, called FENA in clinical phase, is also very weak. This makes children more prone to dehydration since they cannot retain sodium and water as effectively. Next, let's talk about pediatric kidney diseases. There are various kidney diseases, but today I will focus on nephrotic syndrome. Nephrotic syndrome is a disease in which the kidneys produce large amount of proteinuria. and the protein level in the blood decreases, causing fluid to leak from blood vessel into surrounding tissue, resulting in swelling. Depending on the race, about 5 in 100,000 children worldwide develop nephrotic syndrome each year. With higher incidence rates reported in East Asia, including Japan. Nephrotic syndrome usually occurred in children between 2 and 9 years of age, with fluid accumulation in areas like the feet or around the eyes and the abdomen. Here is the pathology of nephrotic syndrome by age. In children, about 80% are classified as minimal change. This one, around 80%. Which this shows minimal change shows no change under light microscopy. In adults, the incidence of membranous nephropathy increases. For nephrotic syndrome of the minimal change type, corticosteroid treatment is markedly effective. However, relapses are very common, so the side effects of steroid can be problematic. But particularly in children, there is a concern about growth suppression due to steroid side effects, which is not something that needs to be considered in adults. The exact cause of nephrotic syndrome is not yet fully understood. It is known that nephrotic syndrome involves abnormality in the glomerular slit diagram. This one. This is the glomerulus. This is the glomerulus. And this is an enlarged view of this area. This is the epithelial cells. This is the basement membrane, and this one is endothelial cells. And the slit diagram is this. The diagram is between the epithelial cells, playing a key role in the filtration barrier, preventing large molecules like proteins or something from passing into the urine. Recently, nephrine antibody targeting this one, nephrine, this red one, are components of this slit diagram have been highlighted as a potential cause. These antibodies are deposited along the basement. This one, this yellow one is poisonine, HG and nephrine. Along the basement membrane, and their concentration is high during the active phase, this red one, and low during remission, this blue one. It is hoped that more specific therapies for nephrotic syndrome will be developed in the future. Another characteristics of pediatric nephrotic syndrome is the high incidence of cases caused by genetic abnormalities. Even among those known to exhibit nephrotic syndrome, there have been numerous reports. Some of these are kidney specific, this one, while others involve other complications, brain, or the heart, or genitalis, and so on. In these genetic cases, treatment with corticosteroid is ineffective. A well-known example of a cause of congenital nephrotic syndrome is a genetic abnormality of this one, NPHS1 and NPHS2. Congenital nephrotic syndrome develops shortly after birth. If renal function is preserved and urine is still produced, proteinuria persists, eventually requiring nephrectomy and dialysis to prevent further protein loss. And recently, GBAS analysis has identified a susceptibility gene for sensitive nephrotic syndrome. Variants were found on the HLA and HLA region involved in immunity and chromosome 19. A closer look revealed that this in chromosome 19, around this one, closer look revealed that this one was a variant of NPHS1 in this chromosome 19. This NPHS1 is a gene responsible for the congenital nephrotic syndrome mentioned earlier. This NPHS1 variant have been shown to regulate NPHS1 messenger RNA expression. Therefore, it has been reported that the etiologic genes for rare single gene diseases can be susceptibility genes for relatively different multifactorial disease. Moving on to pediatric renal failure and dialysis. Top 3 primary causes for end-stage renal diseases in adult are diabetes, 40%, followed by nephrosclerosis, hypertension, or aging or something, and chronic glomerulonephritis. Before Hiroki presented IgA nephritis or something. However, I have never heard of children with diabetes nephropathy leading to dialysis. How about children? In children, hypoplastic and dysplastic kidney amount for about 1/3 of cases, followed by continued conditions such as focal glomerulosclerosis, chronic glomerulonephritis, and congenital nephrotic syndrome. Hypoplasia or dysplasia are malformation of the kidney. In focal glomerulosclerosis, chronic glomerulonephritis, or congenital nephrotic syndrome, many cases requiring dialysis are due to genetic abnormalities. Glomerulonephritis is not so much. In addition, chronic kidney disease, stage 3 to 5 in children, which is GFR less than 60 half, is caused by CACUT. We call it CACUT, congenital abnormalities of kidney and urinary tract, which account for nearly 70% of all age, or 70% of all cases. Malformation and genetic abnormalities are the most common causes of poor kidney function in children. When you think of dialysis, you may imagine hemodialysis, HD. However, there is another type of dialysis, peritoneal dialysis, we call it PD. Almost all children undergo PD. In PD, a catheter is inserted into the abdomen, and the dialysis solution is infused into the peritoneal cavity. This solution absorbs waste products and excess fluid through the peritoneum and are drained out through the catheter after a certain period of time. HD requires 3 to 4 dialysis sessions per week. And with each session lasting 3 to 5 hours in the hospital. HD also requires strict dietary and fluid restriction and is not so suitable for young children because patients need to have a needle inserted every time they receive dialysis and have to stay still during dialysis. PD, on the other hand, is performed at home every night while the patient is sleeping. Since PD is performed daily, every day, dietary restrictions are not as strict. The disadvantages include the risk of abnormal fullness and peritonitis and a heavy burden on the family because it is performed at home. Despite these challenges, there are more advantages. Dialysis is performed at night, allowing the children to attend school during the day. Another advantage is the lack of strict dietary restrictions. Strict dietary restriction can inhibit the child's growth. That's why PD is suitable for pediatric patients. Yeah, that's it. In pediatric, we not only treat diseases, but also consider children's growth and development and help them with as normal life as possible. I hope you can see the difference between children and adults. Thank you.
I'm curious, can adults choose to have peritoneal dialysis if they want? Or
yeah,
yeah.
Actually, they cannot receive a hemodialysis in every week or something.
Okay, they're allowed to. And does the abdominal fullness remain throughout the day, or by the end of the session is the abdominal fullness resolved? Or is it like an all the next day? Are you still like full of fluid?
Hemodialysis is very accurate or exact, but PD is not so accurate. But they can receive a dialysis every day.
Right.
So we check the body weight and also blood pressure.
Okay.
And they usually visit the hospital every month or something.
Okay, see how it's going.
Yeah.
So that's good. So for how long can a child, be treated like this peritoneal dialysis? I mean, or in terms of years or?
Yeah, in average in Japan, average I heard 2 years.
2 years.
Yeah, because after that, they can create a pediatric PD after the kidney transplantation. They can fortunately they can receive kidney from parents.
So, but up to 2 years.
Yeah.
Students and questions? Anything?
So then is transplantation the only long-term solution for these patients?
Yeah, but if they receive transplantation, that they lose about 20 or 30 years.
Really that much?
Yeah. So after that, they need to receive a dialysis again.
Oh, that's clear. I have a question. So in the beginning, you explained the difference between like, yeah, you can like kids, like child and adult, the GFR, right?
GFR.
They are very low,
Mhm.
and around 2 years old, they get almost the same adult level, right? So for in adult, I know yes, is MEL minute by 1.73 meters per minute.
Mhm.
And in newborn kids, the same, they use the same mat
Yeah, yeah,
for
exactly.
Okay.
Yeah.
MEL minute by the 1.73.
Yeah, yeah.
So I have a quick question. So for all these cocoon syndrome, like what is your go-to treatment? What do you recommend?
We don't have any treatment for them. So, we have some drugs for example, RAS inhibitors. Yeah, yeah. Recently, SGLT2 inhibitors or something. We preserve the kidney function. Yeah, as we can, as yeah, as we can possible.
But if there is an obstruction in the urinary tract, do you foresee that it will go away,
Yeah, yeah.
or you perform surgeries?
No, actually, no.
surgeries, no?
If they have they suffering from urinary tract infection,
Okay.
we try to of course we try to treat with drugs or to prevent it with drugs.
And in one of your slides, you mentioned the nephrectomy is one of the treatments for the nephrotic.
Yeah, congenital, yeah.
So when you say nephrectomy, you remove total kidney or part of the
Yes.
kidney?
Yeah, we always usually take both kidneys.
Oh, okay.
Both kidneys.
Both kidneys.
And
Oh,
yeah,
so
of course,
nice.
they have to give the transplantation, right?
Yeah.
In this case, for transplantation.
And no, we need to. They need to receive a dialysis.
Dialysis and then.
Yeah,
Should be on the
yeah.
list.
Congenital nephrotic syndrome is very crucial because they need they're easy to the problem is infection and also thrombosis. So if the kidney function is kidney function decreases, they don't produce urine. So it's almost not so problem because they could not the protein leak from the
So they can diagnose until pregnant or after birth?
after birth.
After birth,
Yeah.
yeah, because I'm obstetrician. I never see that situation. Yeah, I cannot diagnose the congenital nephrotic syndrome.
For ultrasound.
We have ultrasound. Sometimes the abnormality of the kidney we can detect until
With
ultrasound because they cannot make.
Or unilateral, right?
Yeah.
Kidneys.
Yeah. But I first time I see I hear the name of congenital nephrotic syndrome. Yeah, I see.
And are there no genetic markers that they can screen neonatally as a as a marker of like, oh, they might have a congenital condition?
Oh.
Like, are there any like publicly available clinical tests that they can just do like a blood draw from the mom? Detect?
Or I don't know.
Do you think you can screen before, like, anything like?
Are these common enough markers?
Like, markers.
But this kind of nephrotic, congenital nephrotic syndrome is very, very rare.
Yeah.
So
Okay, so it's not
maybe,
like standard panels.
So
Yeah,
how rare is it?
I'm not sure, but I have a patient.
He has
with,
a pie chart. You have a chart, right?
Oh, yeah, yeah,
Percentage of. No, yeah.
that one.
The pizza one.
Oh, the pizza one.
Yeah.
Oh, okay. Oh, yeah, yeah,
Yes.
21. Yeah.
Oh, oh, but it says 7%?
Congenital is 7%, yeah.
So
But
it's
it's
high.
it's.
But 7%
due to
each
the-
the acute.
Oh.
Diarrhea, right? It's a-
Okay, so it's rare.
Yeah.
Yeah.
So then, this 35%, the hypodysplasia, is caused by any disease or specific?
Almost all hypodysplasia is specific in the kidney.
Yeah, like,
And
it is caused by, like a caput or a nephrotic syndrome kind of stuff, or like
No,
that. I'm saying.
congenital abnormality.
congenital,
Abnormality.
yeah.
But there are no biomarkers available right now to
Yeah,
early
like,
detection.
And so children who have these sort of things, do they have to be a certain age before they can receive a transplant? Like how young can a child be to receive a transplant if they need it?
Good question.
If they receive adult kidney from a patient,
Like a parent.
they need to grow more than 75 centimeter
Okay,
or 10 kilogram.
okay.
Oh.
So there's a height and weight requirement.
But in kidney failure situation, they cannot grow
Right.
I see. I
very
see.
slow.
Right.
So 75 or 80 centimeter, it takes us 3 years.
Wow.
So
So they're just on dialysis that entire time.
so we need to support the grow.
It's long enough to be large enough
Yeah, yeah,
to
yeah.
receive the transplant.
They need to growth hormone injection every day, or they need to eat that they feel nauseous.
But how you can preserve the kidney from donor in this time?
Well, it's from a parent, basically, just have to wait there, just wait.
Wait until we are
But
ready.
from parents, right?
Right.
It makes sense.
And what sort of rejection rates do you
Because
children
okay,
experience when
right.
they're getting it from a parent? Is it rare or?
in children, family or parents usually give drugs to children, so it's not so much.
Okay, let's go.
But in adolescents or other grower,
Older children.
yeah, older, they sometimes patient don't take a medicine. So in that
then they
case,
start rejecting it.
Oh.
And so are they on like immunosuppressants the rest of their lives?
Mm.
I have one more question. For the blood pressure treatment for the childhood blood pressure and for the adult blood pressure. So do you have a different drugs or same drugs in a reduced dose? or
Yeah,
something?
almost same.
Almost same.
Almost same. But we don't have any option to treat hypertension or any other diseases. In adult, they have a lot of choice. they have a lot of choice to treat any other drugs, but children is not so much. So we usually use calcium blockers and last hospitals.
Diuretics or some diuretics, right?
Diuretics.
Yeah, or no. Also, they have some, I think it's the calcium blockers, RAS inhibitors, and also some diuretics, right? For kids, I'm not sure. I think so.
That
It's
makes
this-
sense.
I think it's this kind of three types of the drugs major using in kids. I think it's three calcium blockers, RAS inhibitors, and diuretics. You know more than me.
Yeah,
So,
sometimes we use.
Any more questions?
Brilliant. Okay, I know it.
yeah, thank you so much.
Thank you
guys.
so much. Nancy, for your time.
Hi, can I ask a question?
Okay, sure, yeah.
Well, first of all, thank you for the great presentation. But also, I was wondering, like, you said, so like really young patients can get kidney transplants, right? Like, how do they make sure the procedure is, I guess, safe in a way?
Like the donor
Like-
kidney age, does it matter?
Like, do the donors have to be a certain, like, do they have to have certain requirements or?
So the question is, the requirements from the donors during kidney transplantation in children. Do you have any specific requirements or not?
Beyond a genetic match,
Yeah,
like is the donor having to like follow a restricted diet in advance, things like
the
that?
same when you are doing that blood donation, right?
Yeah.
The blood blood types.
Yeah,
But,
yeah,
I
A,
think
B,
it's necessary to match. But HIV,
Okay, so you took that too.
we need to register in Japan, we need to register the bank. So we need to provide information about
Blood type, HLA type.
how long they do they receive a dialysis or something.
So then is the vast majority of children receiving from a parent, or is there a pool of donors that they can receive from? So like 90% come from parents type of
Yeah,
thing? Yeah, something like that.
There's some animal kidney trial. It's like recently.
Yeah.
Yeah, there's a recently.
But that guy died.
Yeah,
Yeah.
they died a couple of months.
Yeah.
I see.
I know, but how about their kids?
Actually, it was kid.
Yeah, kidney, yeah.
It was a kidney.
Was
Big kidney.
yeah, it was 5 months ago.
Yeah, they
Yeah.
did the kidney.
I know the
It was
doctor
it's
is
a kidney.
yeah, he's from Brazil. The doctor.
Oh,
Yeah, but it was in US. They
Yeah.
expressed it.
Yeah.
And then the person died.
After 3 months, 4 months, was the first in the history. Yeah.
Oh, he.
Was originate to how they call this one is animal to humans. Have one specific name for this.
Yeah.
Compatibility, history compatibility.
Yeah, but they,
No, they
Like
had
cross
some.
species or trans.
yeah, they had one specific name
Yeah,
for this kind of like kid
Animal
pig for
Because
was kidney.
those pigs, I think they are also genetically manipulated.
Right.
Yeah,
Yeah.
humanized.
Should be humanized.
Right.
He came from Brazil, the doctor.
I think he studied here a long time.
Yeah.
But he did his.
Yeah, I saw
in Brazil.
the use the name like Japanese kind of.
Yeah,
name.
because there are
Because maybe the roots of Brazil and maybe.
there's a lot of Japanese descendant people in Brazil.
Yeah, you have.
Yeah. I remember.
I think 5% of the population.
Yes.
About 5%.
Yeah.
It's a lot for sure. Yeah.
Wow.
Yeah, it's a large community, Japanese out to Japan, live in Brazil.
So I don't, was it clear for you, or do you have more questions?
Thank you, that was clear.
Great. Okay then. Thank you so much, that's great.
Yep. More pizza.
Hopefully we will have more next year.
Next year.
Yeah,
Next
it
year
was
we
in
should,
Boston Hospital.
okay, okay, we have, so do you have any feedback, the students, Guys, you can stop recording. There's.
They call xenotransplantation.
Xeno,
Xeno.
xeno, like.
Oh, xeno.
Yeah.
Xenotransplantation.
Like xenograft.
She's an
Yeah,
expert.
okay.
That makes
Transplantation.
sense.
And the different species, yes.